This is a pre-course video for the Difficult Vascular Access in Children course. Today I will talk about cannulation tips and tricks. My name is Eimear McCorry and I'm a paediatric registrar. So through the course of this video we will take a stepwise approach to the cannulation of children and discuss how to discuss cannulation with the child and parents, topical anaesthetics, preparing your equipment, your team, choosing the best site, getting the best position for cannulation, inserting the cannula and collecting your bloods, and then finally securing the cannula. So for even the most experienced amongst us, cannulation in paediatric patients can be incredibly difficult. We have patients that are young and can't understand what we are explaining to them. We have patients with complex developmental issues, patients with different communication needs. Our patients are in an unfamiliar environment, full of noise, surrounded by equipment and faces they don't know. Both patients and their families are scared and anxious. We want to share with you today some hints and tips to try and maximise your success in paediatric cannulation. We believe that with some planning and some consideration, we can get this procedure done right the first time. Discussing the need for the cannula. So like any procedure, we should be prepared to explain to the parents and carers and the child, if they're old enough, why we want to put in a cannula in the first place. We should have, before approaching this, considered whether it is actually a necessary part of our management plan and whether an alternative is acceptable. For example, would oral antibiotics be suitable, or perhaps a trial of NG feeds? If you've made the decision to proceed with cannulation, we should explain how this is done and the role we may need the carers or parents to play. We should let them know how we're going to make the procedure as stress-free as possible for the child. We should also let them know, despite our best efforts, we don't always succeed on the first go, just in case we need another attempt. Then with the bigger kids, with good understanding, we should explain to them what we're planning to do and why. We should be prepared to let them know what the procedure entails and answer any questions that they might have. Preparation. Consider topical anaesthetics. Prior to cannulation, you might want to give consideration to the use of topical anaesthetics. When used correctly, they can be extremely helpful in minimising pain for the procedure for their patients. You have a number of choices for this, and this might depend on what your clinical area stocks. If you make yourself familiar with what you have, you can use these to your maximum benefit. First up is Amitop gel, or just referred to as Amitop, and this contains a local anaesthetic tetracaine and needs to be on for about 30 or 45 minutes to actually take effect. It's licensed for children over 1 month. The area that you apply it to will remain numb for 4 to 6 hours. It also increases the size of the blood vessels to the area it has been applied, and so can cause temporary redness. Next is Emla cream, or simply referred to as Emla, and this contains a mixture of topical anaesthetics, lidocaine and prilocaine. It's licensed for children over 1 year of age, and it should be used at least an hour before you plan to undertake the procedure. It, compared to Amitop, only lasts up to about 2 hours. The cream makes the blood vessels smaller and therefore the skin can turn white after application. It's important to mention at this point, however, given the time frame that these preparations take to work, they're only suitable if you actually can feel that the cannulation can wait. Obviously, in an emergency, you might want to proceed immediately. As an alternative, ethyl chloride or cryogesic, or sometimes called freeze spray or freezy spray, can be used. This acts as a local analgesic when sprayed onto the skin. It has no actual anaesthetic properties but works as a vapocoolant, so when it's sprayed onto the skin, it makes the skin cold and less sensitive as the liquid evaporates. This works within seconds, but the effect wears off really quickly as the skin warms up again after a minute or two. It's then also worth mentioning at this point, for the tiny babies, we often use oral sucrose for procedural pain, such as cannulation. The mechanism involved for this is an orally mediated increase in endogenous opioid. There's a 2-minute peak effect through the administration, and you can repeat this throughout the cannulation if required. And the effect of this can often be enhanced when combined with sucking, such as with a dummy. Preparation. Assemble your equipment. So prior to starting out, get all the bits and pieces you need. This may sound obvious, but there's nothing worse than realising halfway through your procedure that you don't have your blood bottles or you have nothing to tape the cannula down with. Everyone will set things up differently, but essentially you will need something to clean the skin, a selection of cannula, and this is where the debate of winged versus unwinged comes in. It's all down to personal preference. Your blood bottles, a syringe with a needle attached to aspirate your blood samples from the hub, extension tubing that has been pre-flushed with saline and a pre-filled syringe attached, steri strips, dressing and a bandage to secure, and of course a sharp spin to dispose of your unwanted sharps. Preparation, assemble your team. Although the idea of assembling a team for cannulation might sound dramatic for what might be considered a straightforward procedure, help is key. I would never approach cannulation in a child, particularly a younger one, without an additional set of hands or a few sets of hands. As a bare minimum, you need someone to hold the child, which is usually the parent, someone else to hold the planned insertion site and help secure the cannula. You should consider who else is around you and who else can help make the procedure less stressful for the child. And if you're lucky enough to have a play therapist in your department, definitely get them involved and on board. Choose the best site. Choosing the best site to have the best chances of succeeding on your first try will be of utmost importance. Your choices might be somewhat limited based on previous attempts taken by others. And it's also worth discussing about how many of our patients with chronic conditions who have had repeated attempts at vascular access over the preceding months or years, their parents will often know exactly where you'll have the best chances of being successful, so do listen to them when they give you some hints. For small babies, the hands and feet are most often used. However, the antecubital fossa and the saphenous veins are useful sites to look at. And I think don't forget about the scalp vein. So scalp veins in babies are really useful, but it is worth mentioning to parents if you're going to attempt this site, because it will look quite dramatic if they're not expecting this. For toddlers and older children, hands and the antecubital fossa are the usual go-to sites. However, the feet can be a good choice, and it's always worth looking at the saphenous veins. Get the correct position. So when you've chosen your site and are ready to proceed with cannulation, you need to consider the position of your patient. A good hold in an optimal position is the key to success. It will ensure stability of the cannula insertion site. This procedure can be difficult enough without trying to hit a moving target. A good position will also allow the child to be distracted by looking elsewhere without seeing the procedure. How you position the patient will depend on which site you're going for and will depend on whether the patient is a baby, a toddler or an older child. For a small baby, it's easiest with the baby on the bed, perhaps swaddled in a blanket with a parent cuddling them or beside them for a little bit of comfort. For toddlers and younger children, you can have them on a parent's lap. They could straddle the parent with legs either side and be cuddled in nice and close to allow optimal control. For bigger kids and teenagers, we ideally don't want to be holding them down, so they're too strong and this will be too distressing for them. And this is where the initial importance of your preparatory steps come into play. If you carefully explain what you're going to do and let them know why you're going to do it, this will hopefully help in the insertion. You should ask the child if they want to see the procedure or not, or would they prefer not to look. Again, use your team members to your benefit. Your play therapist will be invaluable in these cases. Inserting the cannula and collecting bloods. When you're set up with a patient in the optimal position, get your helper to hold the chosen site. Effectively, they're acting as your tourniquet. At this point, it might be helpful to have a look at the pre-course video, Technical Skill of Cannulation, for more details and tips on the actual insertion of the cannula. So after your needle has been withdrawn, you're ready to collect your bloods. Differing from collecting bloods in adult cannula, we drop the blood directly from the hub into the bottles. If you're collecting blood for blood culture, aspirate directly from the hub with a needle and syringe. Securing the cannula. So you felt the relief, you succeeded in getting the cannula in, you've got the bloods taken and it's flushing brilliantly. It's easy at this point to think the hard work is done, but securing the cannula in place is the key step and it needs a little thought. There's nothing worse than coming back later only to be told that the line has fallen out or has become dislodged. So firstly, make sure you still have your extra set of hands with you. You should hold the cannula, ensuring that you always have a good view of the insertion site at all times. You can easily imagine how some kids get super sweaty, so make sure you dry the area with some gauze to ensure your dressing will actually stick. Next, use some steri strips to initially tape down the cannula. These are longer than the actual strips you get with the cannula dressing. How you do this is personal preference, and you'll soon notice that everyone has their own little ways of doing this. Some people loop under the cannula, some people just go across, some stick down diagonally. However you do it, it doesn't matter as long as it's secure and the insertion site remains visible. Next, use your cannula dressing, something with a clear window, with teddy bears and added extra. And it's often helpful to add a little bit of tape to your extension tubing, and this will take a little bit of weight off it to stop it pulling and accidentally dislodging the cannula. And then finally, bandage it all up. This can be done with a normal crepe bandage, or some tube grip will also work. And sometimes the little ones using a sock or a mitt over the top of that can also help. So in summary, cannulating babies and kids can be stressful for all involved, but we want to aim to get it done right the first time. Firstly, consider preparing properly, letting the patient and their family know what you're planning to do. Consider any topical preparations you might want to use. Prepare your equipment, making sure you don't leave anything out. Prepare your team, making sure everyone knows what role they have to play. Choose your best site for maximum success. Optimise your position to keep the insertion site stable. And when all is completed, make sure everything is well secured. Thank you.